All right. Good afternoon, ladies and gentlemen. I would like to thank Dr. Kim and the team. And it's always a pleasure to be here in this Never Say No meeting. All right. All right. So I have to share this one case. This is MH, 7 years old, 19 kilogram, with diagnosis of DILV. TGA, non-restrictive ventricular septal defect, unprotected pulmonary blood flow, had PA band in the neonatal age, and Glenn shunt surgery was done at 1 year plus of age. And you have to believe me because I don't have a serial echo, but this patient has DILV with a competent both AV valve, and the outlet VSD is quite big, and then there is no significant obstruction. And this is recall me the cases that we discussed last night, the restrictive bulboforamen ventricular foramens in patient with DILV TGA anatomy. So this is a pre-Fontan study. This is aortic saturation was 80%, PA pressure mean of 10, and LV EDP of single digit, and transpulmonary gradient was 2 mm mercury. And this patient has no gradient at the pullback from LV to AO. So the Fontan fenestration surgery was done, and the patient was extubated after 48 hours in ICU stay. However, this patient has a problem with high output pleural drainage, more than 10 mL per kilo per hour. So initially, our ICU team is a bit conservative. So this patient was initially managed medically, and then empirically was treated as chylothorax, even though the TG triglyceride was less than 1 gram. So what was the progress of this patient? So a few days after that, we noticed that there is some flow restriction at the fenestration level here. However, there is still good LV function, very trivial AV valve regurgitations, and there's no significant LVOT obstruction. So we decided to bring this patient to the lab. So the aortic saturation was 90%, and the PA pressure mean of 15, and the LV EDP was 10 mm mercury. So this is the angiogram. So you see a lot of collaterals develop, and there's no gland obstruction on the angiogram. There's very good pulmonary arborizations on the right side. And then on the Fontan circuit angiogram shows a very small fenestration and very good arborizations on the left lungs. But at this time, the angiogram was done by a non-interventional cardiologist. So what he did was a coil embolization of epicollaterals, and the later and the next day we had a case conference, and there is argument in terms of disproportionate flow from the gland and also from the Fontan circuit. Gland goes more into the right side, and the Fontan circuit goes more into the left side. So I'm not sure either this is will give problems to the patients. So we decided at that time, I think the cardiologist at that time decided to stop the procedure without fenestration stenting. So the progress of the patients, 1 week after that, patient still had persistent high output drainage despite the chylothorax regime completed, more than 10 mL per kilo per hour, and fluid TG remains less than 1 gram. And again, we have the case conference and decided to go ahead with Fontan fenestration stenting. So this is the 2D echo that showed a Doppler that showed a very restrictive fenestration flow. So this is the second time patient went into the cath study, and this is the angiogram that was done. Aortic saturation was 90%, PA pressure mean of 18, LV EDP slightly high. And then you see this again, the disproportionate of the flow into the right lungs and also into the right lungs and into the left lungs, and you see very restrictive flow into the fenestration. So we decided to go ahead with the stenting the fenestration. So we changed the sheath into long sheath, 8 French Malins, and then using the JR over the Malins, and with guidance by Terumo guide wires. So This is the JR 4 French, park into the fenestrations and go across into the fenestration into the left atrium. We tend to usually pre-balloon the fenestration to be able to advance the stand. So we use a balloon, a 5 milliliter balloon, to open up the fenestrations to be able to help us to advance the stand. So, and then later we change the guide wire into unplugged steel guide wire as a preparation for the stenting procedure. So, and the stent was delivered and parked at the mouth of the sheath. And this is, at this time, we don't have Cook formula stent. I think we have problem with suppliers of Cook formula stent. So what we have is only 1910 PG stents, which are mounted over admiral balloon of 7 millimeter diameter. All right, so you can see the distal part of the stent. All right, so the intended procedure is actually to open up the distal part, and then the sheath is in the middle, and then pull the sheath and open up the proximal part. So this is the intended procedure. So, however, on my left is my junior fellows, and on my right is my senior fellows. So I asked the junior fellow to hold the sheath, and I asked my senior fellow to inflate the balloon. So what happened? So she was in tremors, and then for some reason forgot to bring the sheath back. All right, so this is the initial dilatation. At this hour, I already realized there's a problem because your stents move into the atrial side. So, like it or not, yes, you have to fully dilate it, the stent, because it's already out. So this is a fully dilations, and I always remember Frank philosophy: any dub, take pictures. All right, so yes, there's no doubt actually, but I take pictures and I know the stent is already in the left atrium. All right, so what should I do? And I believe I don't have time for the voting system, but again, so it's either option, either to retrieve the stent only and stop, or retrieve and reposition the stent, or ask our surgical colleague for the stent removal and enlarge the fenestration. So anybody? So I believe the intervention will do the second thing, the second option. So again, I have the pleasure enjoying Jae-Young meeting last year, so about the principle of retrieval of the ASD device. So I remember that exactly. So I applied that 5 C's principle. So first is to be calm, all right? Don't panic, because everybody in the cath lab rely on you now, all right? Second C is to concentrate, be focused, and never lose the guide wires, because that will be your savior. And my third C is to be constructive. You have to start planning how to retrieve back the embolized stent. And then, of course, you have to check and confirm what is available on your shelf. And also, this is, you need to pre-prepare, and you need to brief your team that this is something that you need to be, the device that need to be available for your procedures. And again, not to forget, the last C is to communicate. You have to call your colleague. And then, of course, being in IJN, I have to call this guy. All right, so I have to call Dr. Alwi. I knew that he was busy in his clinic, but my call is simple. All right, Dr. Mazni, don't go anywhere. I may need your help. All right, and of course, I call my surgeons to stand by in case the procedure was unsuccessful. And again, I need to call my intensivists to get ICU bed be prepared. Not only these 5 important C, I have to also add 2 more C's, all right? Yes, you need to counsel the parents, all right? Prepare them for the worst case scenario. And the 7th C is also important. cancel the other case, concentrate to this case. Okay, so what did I do? So the first one, I tried to retrieve, of course you need to upsize your marlins. Now I already upsized the marlin sheath into the 10 French diameter, and I tried to grab using the 10 millimeter gooseneck snare, try to grab the stent, and you know that you may have a difficulty because of the open stand. Okay, so what can I do? So I cross the snare again, but this time you try to inflate the balloon, and then you try to again advance the snare over the balloon. And the first time I was failed again. I think because the snare stuck into the stand, but don't stop. All right, so I inflate the balloon again, but this goes simultaneously, and I open up the snare and goes and grab the stand. Okay, now you have problem. How do you bring the stand back into the sheath? Okay, and you know now you already stuck. Your stand already caught, but again balloon, you already deflated the balloon. But the retrieval into the sheath is also something that you need to worry about. Again, you try to bring the stand back into the sheath. It's stuck to the mouth of the sheath. You try hard. This time you try harder. But again, you still fail. So what I did, I re-advanced the stand back into the atrium, but this time I advanced back the balloon. So the intention actually to catch the proximal part of the stand, crush it, and then try to bring back the stand into the sheath. So that was what was done. So the balloon was inflated, the snare was released, and I tried to cut the proximal part of the stand. So this time, yes, you have no open strap, and then you try to pull, and then now the stand is ready into half, only the proximal part into the sheath. But my senior fellow now, he pulled out the sheath and accidentally it crossed into the fenestration and into the Fontan circuit. And I took pictures, and you see this. But again, you see this open stand from the snare. So I have difficulty again to bring back the stands into the sheath. And you see there's some tear into the mouth of the sheath, which is making things difficult. All right, so what should I do next? So the stand now stuck into the mouth of the sheath. So I need to upsize, maybe I need to upsize the sheath, but how? Right now I have the snare, and I have the balloon and also the stands. So I may need another access, but where? Neck or another femoral, or keep pulling into the sheath. At this time, after 3 or 4 hours, you may have top block. So, like it or not, you have to bring Mazni in. Okay, just a simple instruction: put 14 French sheath into the jugular vein. So this cross into the gland, and then try to snare, open up this 25 millimeters gooseneck snare. And this one was catch. So this one, okay, caught and released. All right, so now you did the pictures. There's hardly any fenestration. So I try to re-balloon the fenestration. but you know that balloon will not help the fenestration. So what's next? You have already 3 to 4 hours procedures, reattempt a stenting procedure, or refer for the surgery, enlarge the fenestration, or stop and rest, or reattempt the stenting later. So at this time, I chose number 3. We have to stop at certain point, and then patients also might be compromised if you continue further. You have to use a lot of contrast and so on. All right. However, a week later, then we decided to go ahead and do the fenestration stenting. But this time, you have your senior colleague on your side, and then you know that you have hemodynamics probably the same, and then angio showed a restrictive fenestration. And then again, limited stent option that we have, use a 1910 over Admiral 12mm balloon. So this is what was highlighted before. This is the initial dilatation, the intended procedure that I have highlighted in the previous slide. So you have a very good stent full inflation, and you see the waist open at the fenestration as well. And this is the latest, sorry, this is the retrieval of the balloon after the inflation. And then you have the final angiogram. It shows a very good stent position and also the fenestration flow. And then PA pressure drop into 14, and patient has aortic saturation drop from 97 to 90%. And the pleural drainage dry up after a few days, and this patient discharged saturation at 86% and was discharged a week later with warfarin. So this is actually the follow-up after 6 months. Patient is asymptomatic, saturation under room air is 88%, and very good LV function, non-restrictive bulbo-ventricular foramens, and very good stent flow at the fenestration site. So what is the take-home messages for this patient? So managing Fontan fenestration is never easy. All right, sometimes you may need to open, and sometimes you may need to close. And then you have to make sure there will be appropriate device and also equipment available before any complex intervention, and you have to look for alternative before you proceed of any kind of complex intervention. And remember the applications of 5Cs principle if you face a complication. Be calm, concentrate, constructive, and checking, confirming, and also communication and counseling. Thank you very much.